My greetings to everyone. I'm Dr. Gautam, first year DM resident in Department of Clinical Immunology and Rheumatology, IPGMR Institute, Kolkata. And today I'll be sharing an interesting case of an 18-year-old girl who has been symptomatic for the past couple of years when it initially in October 2019 started with multiple painful swollen joints involving the small and large joints of both upper and lower limb. The involvement was bilateral, symmetrical and additive, and in addition she also reported history of claudication pain involving the left calf, which was insidious in onset and gradually progressed. And in the form that she used to tell that it used to be more frequent, more severe, and used to get precipitated at the lesser amount of distances she used to walk. And this was accompanied by history of constitutional symptoms in the form of fever, which was not associated with any history suggestive of localization, fatigue, and significant loss of weight from 48 to 34 kilograms over a couple of years, and with significant loss of appetite as well. And for these complaints, however, she was not on any treatment. Now, in February 2021, she reports history of painful red eye, which was associated with photophobia and blurring of vision, and that which got improved with topical application of the eye drops that was suggested by an ophthalmologist. And there were a total of 3 to 4 such episodes, and the last episode was reported in September 2021. So in June 2021, she was hospitalized at a local hospital with complaints of headache, vomiting, and one episode of convulsion. And in the hospitalization, she was found to have elevated blood pressure recordings, and the MR brain imaging revealed edema in the right frontoparietal occipital lobe, possibly hypertensive encephalopathy. So she was started on antihypertensives and anti-epileptic medications and was discharged, and she was compliant to the medications. Now, in September 2021, she was again hospitalized with complaints of acute onset breathlessness, which with NYHA class 4 associated with orthopnea and palpitations. Though this was the reason for which she sought the medical attention, she also had fever and dry cough, which were going on for the past couple of months. Now, labs revealed neutrophilic leukocytosis, elevated inflammatory markers, the ESR and CRP. In view of her breathlessness and orthopnea, ECG was done that revealed STT changes involving the anterior and lateral chest leads. Echo was done that revealed global hypokinesia with rejection fraction of 35%, and there was a large pericardial effusion. Ultrasound abdomen was done that revealed asymmetry in the kidney size. The right kidney was small, 8.8 centimeters, in comparison to the left kidney. The suprarenal aorta, abdominal aorta, was actually dilated was of size 3.5 centimeters with thickening of the vessel wall. So she was treated as a possible large vessel vasculitis with myocardial involvement and right renal artery stenosis. So she was treated with dexamethasone 4 milligrams twice daily. That amounts to about 1 to 1.5 milligram per kg prednisolone equivalent for her body weight, and diuretics and antihypertensives and antibiotics, following which she improved symptomatically. However, she had persistent fever and dry cough which were still present, and for these complaints she actually received a second opinion in a private hospital where she was evaluated extensively. So on evaluation, she underwent basically the CT angio of aorta and its branches, where there was involvement of aortic arch, thoracic, as well as the abdominal aorta. So all the three were fusiformly dilated with diffuse wall thickening. The aortic branches, there was a subclavian artery stenosis noted. There were multiple collaterals seen in both the forearms bilaterally. As she was complaining of the claudication pain involving the left calf, CT angio of lower limbs done that revealed diffuse narrowing of left distal external iliac, common and superficial femoral artery. There was right superficial femoral artery narrowing as well. The branches of the aorta were also narrowed from its origin. That is the celiac trunk, the superior mesenteric artery, the bilateral inner arteries were narrowed. There was non-visualization of the left pulmonary, upper lobe pulmonary artery. So these are the CT images of our patient. So as I was suggesting, there was a fusiform dilatation of the abdominal aorta with the diffuse wall thickening, as you can see over here, and the diffuse wall thickening of the left common carotid artery as well. So the dilated aneurysm dilatation of the aortic arch you can visualize over here. But in addition, what was also seen in this CT imaging was the pericardial effusion, the large nodular opacity involving the upper lobe of left lung, multiple nodular opacities involving the middle and lower lobe of the left lung. There was a cortical erosion in the acromion process of left scapula. So these were the additional findings. She also underwent a whole body PET scan that actually revealed multiple metabolically active FDG avid necrotic lymph nodes involving the cervical, the mediastinal, the mesenteric, and the retroperitoneal regions. She also had multiple metabolically active nodular opacities involving the left lung. There was a high FDG avid lytic lesion involving the acromion process of left scapula. There was a low-grade FDG uptake involving the arterial wall along with the arterial wall thickening. So that was noted in the whole body FDG PET. So the same things which I actually mentioned in the previous slide, that's actually mentioned over here. So she was basically after the evaluation, she was started on prednisolone 10 mg and antihypertensives were continued, and after which she was referred to us for further evaluation and management. So what was found? So we examined her, and on examination there was mild pallor, there was significant lymphadenopathy, there was of the cervical and the left supraclavicular. There were multiple matted lymph nodes, firm lymph nodes of which were mobile and non-tender, and of size more than 1 centimeters. There was asymmetry in the peripheral pulses. The left axillary, brachial, radial, and ulnar were feeble. The left femoral, popliteal, posterior tibial, and anterior dorsalis pedis arteries were not felt. There was asymmetry in blood pressure recordings. The right brachial artery recorded elevated blood pressure of 170 upon 90. The left brachial was 120 upon 90. Right lower limb recorded systolic blood pressure of 150, and left lower limb the blood pressure was not recordable. There was bruit involving the left common carotid artery and the right renal artery. On fundus examination revealed bilateral grade 1 hypertensive retinopathy changes. So after the history and examination, she had the following components: musculoskeletal involvement in the form of inflammatory polyarthritis, constitutional involvement in the form of fever, fatigue, significant loss of weight and appetite, hospitalization for possible hypertensive encephalopathy, the involvement of a large vessel in the form of vascular claudication pain, pulse asymmetry, hypertension, bruit, involvement of aorta and its branches on CT angio, the cardiovascular involvement in the form of myocarditis, heart failure with reduced ejection fraction, pericardial effusion, hypertension with its end organ damage in the form of concentric LVH and grade 1 hypertensive retinopathy. She had elevated inflammatory markers, neutrophilic leukocytosis, and negative autoimmune serology, which she underwent in outside hospital. So, but in addition, she also had few other components that were not explainable. That was basically recurrent painful red eye, which was associated with photophobia and blurring of vision. Dry cough, which was going on for a couple of months, possibly because of nodules in the lung, significant cervical, supraclavicular, mediastinal, and mesenteric lymphadenopathy, lytic lesion involving the acromion process of left scapula. So with the components, the possible differentials that we thought was basically the considering her age, gender, ethnicity, and the involvement of aorta and its branches. She was possibly thought to have large vessel vasculitis, possibly Takayasu, and type 5 because of the involvement of aorta and its branches above and below the diaphragm, with disseminated tuberculosis considering the endemicity, and or the Takayasu arteritis type 5 with lymphoma. So she was evaluated accordingly, and labs again revealed neutrophilic leukocytosis, elevated inflammatory markers. CRP was 12 against the cutoff of 0.3. The liver and renal functions were absolutely normal. Urine routine was normal. She was evaluated for tuberculosis. Sputum for AFB and CBNAT were negative. Lymph node biopsy was done from the left supraclavicular lymph node, and that were negative for AFB and CBNAT. Ultrasound again confirmed asymmetry in kidney size with dilated suprarenal abdominal aorta. There was improvement in ejection fraction from 35 in the September 2021 to current admission in to about 45%, possibly because of the dexamethasone which she has received, and there was evidence of concentric LVH. There was mild AR, and there was improvement in the pericardial effusion as well. So it was just 3 to 4 mm all around right now in this admission with us. The ultrasound left scapula revealed cortical irregularity or erosion in the acromion process of left scapula. So on the biopsy, the histopathological examination, there was areas of necrosis surrounded by palisading histiocytes, epithelial cell granulomas with Langhans cells and foreign body giant cells, compatible with the necrotizing granulomatous lymphadenitis consistent with the Mycobacterium infection. So so the final diagnosis which we could possibly made at the end of evaluation was Takayasu arteritis type 5 with involvement of aorta and its branches above and below the diaphragm, with components of involvement of large vessel disease, the cardiovascular involvement, musculoskeletal involvement, and constitutional features. And in addition, she also was diagnosed with disseminated tuberculosis with lung nodules, significant matted cervical, supraclavicular, mediastinal, and mesenteric lymphadenopathy, lytic lesion involving the acromion process of left scapula, pericardial effusion, and recurrent painful red eye. So she was continued with prednisolone 10 mg once daily, and the blood pressure was optimized with antihypertensives. The anti-tubercular therapy was started from the dots, and she was planned for second immunosuppressant cyclophosphamide after 4 weeks of anti-tubercular therapy for her myocardial involvement. And in February 2022, when she had come to us for the follow-up, she was doing well. ITAS was 0. She had no new complaints or no worsening of her complaints. She was afebrile and her inflammatory markers were normalized. She was compliant to medication and had received 3 pulse of cyclophosphamide already with the background ATT going on. So what is the importance? Basically, here is a systematic review which got published recently in May 2021. What they tried to look into was that this review was basically done with an aim to emphasize the linkage between the the Mycobacterium tuberculosis and etiopathogenesis of Takayasu. So what was seen in this 6 and this total altogether these 13 published articles is that what they tried to look into was basically there were about 196 patients of Takayasu that were diagnosed with Takayasu, and of the 196 there were about 68 patients who had either concurrent or the prior infection with tuberculosis. And the authors actually favored this association of the infection either current or prior to the occurrence of arteritis. So as we can see here, say for example in this study by Soto et al, what they looked into was they actually did the autopsy from the aorta of the patients with Takayasu, and what was found is that there was increased expression of the Mycobacterium tuberculosis genes from these patients. So the IS6110 and HUPB genes, which were genes of Mycobacterium tuberculosis, they were actually expressed in from the aorta of Takayasu arteritis patients, strengthening the association. So, as we all know, Takayasu arteritis is a granulomatous vasculitis involving the large vessels, the etiology of which is possibly not known, and autoimmunity is in an individual with a genetic predisposition and with super added environmental risk factors, commonly of which the most important one is Mycobacterium tuberculosis, which the authors have actually tried to favor the association between the Mycobacterium tuberculosis and the etiopathogenesis of Takayasu. Why? Because of the significant correlation. Because of what was observed in the systematic review, which I showed earlier, was that the patients with Takayasu had actually increased response to the MAN2. There were many patients who were actually MAN2 positive, strongly positive for MAN2, who were actually diagnosed with Takayasu arteritis, and the possible reason which they have uh, uh, implied to that is because of the homology between the heat shock protein of the Mycobacterium with that of the heat shock protein of the arterial wall of the host. That is the heat shock protein 65 kilodaltons. And as I said, in the study done by Soto et al, there was increased expression of the Mycobacterium tuberculosis genes from the patients whose autopsies from the arterial wall was done. And the third one, strengthening the association, was the response to tubercular therapy. So in the various cases, what they actually found out, done by the Agostinis et al and Mora et al, what they looked into that there was actually resolution in the Takayasu arteritis symptoms with complete return of the affected pulses following treatment with ATT and background corticosteroids. But the same was not confirmed by the case which was published by Kemery et al, where the anti-tubercular therapy did not affect the Takayasu arteritis vasculitis, neither did it prevent the new relapse. So the effect of anti-tubercular therapy on Takayasu symptoms remains debatable. However, with anti-tubercular regime, most of the authors portrayed reduction in the Takayasu arteritis symptoms with complete return of the affected pulses. Though what has to be kept in mind is that there was concurrence treatment with combined corticosteroids and anti-tubercular therapy in these patients who had actually responded. So finally, what I would like to suggest is that Takayasu arteritis is the granulomatous vasculitis of involving the large vessels of unknown etiology, and most of the studies which have been published in the literature actually favor the association that either the latent or the active Mycobacterium tuberculosis infection to be one of the definite triggers for etiopathogenesis of Takayasu arteritis, as proven by various studies by the rates of increased MAN2 positivity or the increased expression of Mycobacterium tuberculosis genes from the autopsy samples of the aortic tissues of Takayasu arteritis patients, and the response to anti-tubercular therapy as well. So one should always, so it has been found consistently that tubercular arteritis, tubercular infection either in the present or in the past could possibly be a causal association to the Takayasu arteritis rather than a casual. So these are my references, and